All right, let's go ahead and get started. So welcome back to those that were joining us from our afternoon sessions. Today's virtual neuromuscular conference has been dedicated to health issues and neuromuscular disorders. This session will be on balance and falls and neuromuscular conditions. Before I go ahead and introduce the topic and get into the presentation, I wanted to take a moment to explain that today's session is available in English and in French. So I ask you to go to the interpretation setting on your screen and select English or French. Select the language of your choice. I'll pass it over to one of our directors on mission, Marie-Hélène Bolduc. She will be able to explain this instruction also in French. Go ahead, Marie-Hélène.
Alors, bienvenue à toutes et à tous pour cette dernière conférence de notre colloque sur les maladies neuromusculaires qui va avoir comme thème l'équilibre, les chutes et les maladies neuromusculaires. Alors, je veux seulement vous informer que la conférence est disponible en français et en anglais. Vous n'avez qu'à sélectionner l'icône en forme de globe terrestre, interprétation dans le bas de votre écran, choisir la langue de votre choix et ce sera la langue que vous entendrez tout au long de la conférence. Alors, merci beaucoup et bonne présentation.
Thank you all. Thank you so much, Marie-Hélène. So interestingly, prior to joining Muscular Dystrophy Canada, I am a pediatric audiologist and a past vestibular trainee. So what that means is that's actually how I got familiar with the neuromuscular community and individuals with neuromuscular diseases. As an audiologist, I would test individuals' hearing and their balance. And so I'm really happy today to present information on balance and neuromuscular disorders. And following my presentation, we have Ming, who's here today. She's a physiotherapist consultant and a physiotherapist at Fraser Health. And she will be speaking about fall prevention, which is critical. So I'll go ahead and stop sharing my screen here and share the slides for today's presentation. All right. So today I will be talking about muscle weakness, postural instability, and falls. The key goals for today is to discuss what is the vestibular system, what is dizziness, what is postural control, how are falls related to the balance system, how are falls related to neuromuscular disease. So when we think about the ear, we're often thinking about the hearing system, our ability to hear. But within that inner ear, the cochlea, within that inner ear is where the vestibular system is housed. So not only are our ears responsible for hearing, but our ears play a huge role in maintaining balance. The balance organs are located in the inner ear. I want you guys to think of the vestibular system as a set of sensors. It's a set of sensors inside the temporal bone that are exquisitively sensitive to our motion through space and our position with respect to gravity. So within that inner ear, there is 3 semicircular canals, and these look like 3 tiny connected tubes. It's their primary job to help you balance. The canals are filled with fluid and they're lined with tiny hairs. So when you move your head, the fluid in the canal sloshes around, hence moving the hairs. The hairs send this position information as signals through the vestibular nerve to your brain. The brain then interprets these signals and sends messages to the muscles that help to keep you balanced. So you're probably thinking, well, when you spin around, you feel dizzy. Well, why does that happen? So when you spin around and then stop, the reason you feel dizzy is because the fluid in those semicircular canals continues to slosh around for a while, which gives your brain the idea that you're still spinning even when you're not. So when the fluid stops moving, that's when the dizziness goes away. Now I'm already starting to use this term dizziness. And some people tend to use the word dizziness, analogous or kind of synonymous to vertigo or disequilibrium or lightheadedness. So I'm going to go ahead and break that down today and also tell you what we'll focus on for this presentation. So dizziness is a broad term. It's used to encompass a wide variety of symptoms. And the most common of those symptoms are vertigo, disequilibrium, and lightheadedness. Vertigo is that illusion of movement of either yourself or of the environment. You might feel like the room is moving. So that could be due to imbalance of neural activity in the vestibular pathways. Lightheadedness is the sensation of feeling faint or passing out due to momentary reduced blood flow to the brain. Disequilibrium. Now, this refers to the loss of balance. It refers to unsteadiness while standing or walking. And this could be because of a variety of factors. It could be because of a problem with the central nervous system, with the musculoskeletal system, visual system, vestibular system. And for the remainder of this talk, I will be focusing on disequilibrium. So I want you all to think of the vestibular system as this internal GPS system for your body. Think of the brain as the car. And so your vestibular system is that guide. It sends the messages to the brain, which sends signals to the different roads in your body. The different roads being, again, muscles, joints, tendons, hand-eye coordination, behavior, motor planning, auditory, visual. And it's really that guide that helps to coordinate the response that you have when there is unsteadiness. So the vestibular system can be thought of as both a sensory system and a motor system. So let's think of you tying your shoes. In order to do that act, you must have balance coordination, muscle tone, you must have fine motor skills, and hand-eye coordination. It really takes a combination of all of those skills to accomplish this one simple task. So the act of maintaining, achieving, or restoring a state of balance during any activity is called postural control. Postural control is your ability to control the body's position in relation to a task like tying your shoes or the environment. I've already started to allude to this, that in order to maintain balance, you really need to rely on a number of different systems. So how do you have postural control? You're relying on the neuromuscular system, the musculoskeletal system, and the sensory system. It's really that integration of all of those systems through practice from childhood that allows your postural control, your ability to maintain balance, to become automatic. And another way to think about this is maintaining balance depends on information received from the brain, by the brain, from three peripheral sources: the eyes, your muscles and joints, and vestibular organs. All of these three sources need to work together and provide that key information in order to maintain balance. So I'm highlighting that the neuromuscular system is critical in maintaining postural control. So you're already seeing where I'm getting at this is that if someone has a neuromuscular condition, then there may be an inability to have effective postural control, or maybe more challenging. So really the selection or the timing of the muscles, the muscle strength, the base of support, all of that will contribute to your ability to maintain orientation in the environment. So balance requires keeping your center of mass over the base of support during static or dynamic situations. In other words, controlling the body's position in space of stability and orientation. What you see in this image here is a test that we typically do in the vestibular clinic, where it is testing different dynamic positions. So your feet can move forward or backwards without warning, and we see how your body responds to that movement. And what we know is muscle strength is a potentially important factor in contributing to that postural control. Proper postural control is really when an individual is able to engage in those static, meaning staying still, and dynamic activities. And in real life, that's sitting, standing, kneeling, crawling, walking, and running, with your ability to contract the appropriate muscles required for that midline posture, as well as your ability to make small changes in response to those changes in movement, and making compensatory motions as well. If you are feeling a sense of unsteadiness, you can make changes using your muscles to your advantage to help reduce the fall. So neuromuscular conditions broadly can adversely affect postural sway. Impaired postural control has been observed in individuals with neuromuscular conditions. Patients will report lack of balance and coordination as a main symptom affecting their mobility and daily living. Interestingly, when you look at the literature, so what has been published in the scientific and medical literature on neuromuscular conditions and balance, it's quite limited. But when you speak to clinicians who work with patients with neuromuscular conditions, they'll often report that yes, clients or patients are often telling us that their increase in falls was one of their first signs of having a neuromuscular condition as an adult. They might notice that. And also those increase in falls, and we'll talk about this, is what will lead them to using different mobility aids or adjusting their lifestyle. So balance deficits can reduce mobility, it can reduce independence, and can lead to falls and injuries, which ultimately impacts overall quality of life. Over the summer, we launched a study at Muscular Dystrophy Canada. We were looking at the economic impact of neuromuscular disorders, but also quality of life. And something that we heard loud and clear, and that study is ongoing. So if you haven't done it yet, you're welcome to go to oursurvey.ca/MDC in capital letters. And what we heard from Canadians affected by neuromuscular disorders is that they did have a number of falls. Sometimes that required hospitalizations and sometimes that did not, but that really was important in negatively affecting their quality of life and their independence. So I mentioned that muscle weakness is a risk factor for falls. So what would we define as a fall? A fall is defined as an event that leads to an unplanned, unexpected contact with the supporting surface. So that still is a fall if you even fall into a chair or a wall and not to the ground. And I've mentioned that falls are commonly reported by people with specific neuromuscular conditions. In general, falls can lead to loss of mobility. It could potentially lead to a hip fracture, loss of independence, depression, arm injuries, or death. What you see on your screen is a grading scale that is used by some clinicians to talk about whether it's nearly a fall, so a slip, a trip of loss of balance, so you didn't fully fall to the ground, a fall, which is a grade 2 fall, which would mean that you fell to the ground or a lower level like a chair, but you didn't receive medical attention. A grade 3 fall is a fall to the ground or a lower level for which you received medical attention, but was not admitted to the hospital. And a grade 4 fall is identified as a fall to the ground or a lower level like a chair, and you were admitted to the hospital. In addition to experiencing falls, individuals with neuromuscular conditions are reporting a fear of falling. So a fear of falling is a lasting concern about falling that may cause a person to stop doing their activities that they are able to do, but this fear is stopping them. And so when we think about the World Health Organization, anytime a disease or a health condition impacts our activities of daily living, that is something that we should look to see how we can support it from a rehabilitation perspective. So in other words, a person can develop anxiety towards usual or normal walking or mobilizing with that perception that a fall will occur. And this typically happens after a fall. As well as the risk of immediate injury, I had mentioned that falls could also lead to an avoidance of activities. And this fear has been documented as a prominent reason for use of a wheelchair. While there isn't robust literature on falls in patients with neuromuscular disorders, I did want to point to this one paper that talked about that 27%, or there's an increased risk of 27% for falls in patients with neuromuscular conditions. Falls frequently cause injuries, It was about 75%, 79% rather, experienced minor injuries and 5% experienced major injuries. 58%, so more than half of individuals that were studied in this article experienced the fear of falling. And as a result, 48% reduced their activities. There was a study that I came across with adults with body inclusion myositis, and that study mentioned that they avoided a range of activities and locations due to fear of falling. The most common perceived cause of falling was weakness in their legs, but tripping, loss of balance, and uneven, rough surfaces was also frequently blamed. The most common activities or locations that an individual avoided, an individual body inclusion myositis, which is a neuromuscular condition that falls under MDC's umbrella, were stairs and steps. That was reported by 44% of individuals. Uneven ground, 31%. Slopes or hills, that was reported by 26%. Unaided walking, physical activity, the sport, the gym. Other activities reported by smaller proportion of respondents included fast or long distance walking, using public transport, using low furniture or public conveniences, leaving the house alone. So the relationship between fear of falling and physical performance and quality of life has also most recently been studied in children with Duchenne muscular dystrophy. In this study, 30 boys who are ambulatory diagnosed with Duchenne muscular dystrophy participated in the study. The study suggested that although the boys did not talk about a fear of falling, and that wasn't reported as a primary concern by boys who are ambulatory with DMD, it was mentioned that physical assessments and precautions should be taken into account, especially knowing that fear of falling could have an effect on quality of life and physical performance. So far, you've heard me say that falls are more common in individuals with neuromuscular conditions, but the rate of serious injuries from a fall, so secondary to a fall, meaning that injury that might result from a fall, are similar to others. So it might be similar to those who experience a fall from old age. And what you also see on your screen is that neuromuscular conditions, the term neuromuscular disorder is a broad term that can represent different disorders: Friedreich's ataxia, GBS, muscular dystrophies, myotonias, myasthenia gravis, and it all really depends on where that damage is. All could contribute to muscle weakness, all could contribute to being at risk for a fall, but they are affected differently based on which muscle groups are affected. An increased rate of falls and stumbling in patients were found with individuals who have myotonic dystrophy 1 or Steiner's compared to healthy controls. Myotonic dystrophy is known as a multi-system disease. That basically means that it affects different parts of your body. So patients can experience cataracts, frontal lobe dysfunction, attention impairments, myotonia. And the reason why I'm bringing up myotonic dystrophy as an example here is, while what I've done in the talk so far is set up that if you have muscle weakness, then you're at more risk for falls. But we know from the earlier slides that if there is damage to other systems like the visual system, then you might be at an increased risk for fall. So this is where I can see an additive effect. So an individual with myotonic having that multi-systemic effect on their body, on their vision, that could also contribute to falls as well. Also thinking about even the different medications that an individual is taking. We had a great talk earlier this afternoon by Dr. Ward and talking about side effects of certain medications for Duchenne, some of which could contribute to vertigo or dizziness. So those factors can contribute to an additive effect in terms of risk for falls. The location of the weakness, the location of that muscle weakness might also influence the risk and the mechanism of the fall. And it might then necessitate a particular intervention or rehabilitation strategy. So what you see on your screen here is if it's distal muscle weakness, that could increase the risk of stumbling. However, when proximal muscles are preserved, individuals are usually able to correct balance after stumbling, and you see the damage there, potential weakness there. What if the potential weakness is in the proximal muscles? This could lead to a fall because of inadequate balance correction in the case of an external balance perturbation. What if there's combined distal and proximal muscle weakness? This could lead to a substantially increased risk of falls because of an increase in stumbling rate, as well as your inadequate ability to correct, to compensate after that stumble. Trunk muscle involvement is most critical for loss of balance in patients with FSHD. And it may help to develop rehabilitation strategies. So focusing on that trunk muscle to prevent patients from falling. This right here is a table or a schematic where you see that neuromuscular disorders that have non-muscular signs like reduced vision or weight gain could lead to potential for a fall or increased fall risk. But also if there's muscle weakness that affects your neck, or let's say the trunk and hip, like those that have limb girdle or other muscular dystrophies, or muscle weakness in the hand or ankles, like in individuals with myotonic dystrophy, then there may be this increase in stumbling or increase in having a fall, all because it affects your ability to use your hips or your ankles in order to compensate for that stumble. Referral to therapy is not routine for people with neuromuscular conditions. So in the literature, it has often talked about that while patients or clients will report falls and see physiotherapists or occupational therapists, they're most likely not going to the physiotherapist for balance-related rehabilitation. So, and it's unlikely that an individual plan regarding falls is there for individuals with neuromuscular conditions. With that said, there is data to show that the range of potential interventions, which could include walking aids, physical therapy for gait retraining, home exercise for gait stability, changes in the home environment to reduce the fall risk, and treatment of the underlying neuromuscular condition can really help to improve fall risk. And so you see on this screen here, this is from the Cleveland Clinic looking at the data, I believe, of 70 patients with neuromuscular conditions. Those that did engage in balance-specific rehabilitation did see about a 43% improvement in their walking, but also reducing the number of falls. Patients with Becker and limb girdle muscular dystrophies with knee muscle strength as low as 3% of normal strength. It's also been documented in the literature that aerobic and strength training has positive effects. And I welcome you all to watch the webinar that we had last week on FSHD and exercise that helps to highlight this point as well. So while I have made the link that instability could lead to falls, I should say that when stability is severely impaired, individuals could opt for and do opt for a wheelchair. And in that case, falls no longer become a high risk for them. Having said that, it is important that even individuals who use mobility aids are mindful of their balance, of their risk for falls during transfers, and caregivers should be aware of this as well, and something you should speak to your physiotherapist or occupational therapist. I'm going to pass it over to Ming to talk about fall prevention, but I wanted to mention that fall prevention is really important. Modifying your home to making sure that you can live independently and safely is critical. Talking to your multidisciplinary team. So as an audiologist, I could be a member of a neuromuscular team, but a physiotherapist, an occupational therapist will be really critical in helping you find a good balance and exercise program keeping in mind your neuromuscular condition, but knowing that even two individuals with the same neuromuscular condition can be affected in different ways, it's important to get that individualized support. As an audiologist, it would be wrong of me not to end this talk also to say it's important to get your vision and hearing checked annually. We heard today that your vision is important in helping you to maintain balance. Really maintaining balance is a result of multiple or a complex interplay of different systems. So making sure that you are checking vision and hearing, and knowing that your hearing and balance are housed in the same organ, it's really important to monitor your hearing as well. I do welcome you all to email me if you have any questions related to this topic, or at any time if you have any questions related to our research hotline. I wanted to thank Muscular Dystrophy Canada for an opportunity to help host these webinars and this virtual neuromuscular conference. I will pass it over to Ming, and also to Stacey Lintern. I was reflecting on my training as a vestibular specialist and as an audiologist, and I look to her now as a mentor and knowledge translation and in delivering our programs and services here at MDC. I'll stop sharing and I'll pass it over to you, Ming, to share your presentation on fall prevention.
Hello, this is Ming Liao. I'm just gonna see whether I can share my screen with you on this. Can you see this?
Looks great, Ming. If you just put it on full screen mode, that'd be excellent.
Great. So thank you for muscular dystrophy to invite me to do this presentation. It's been a really topic of mine that I've been really been involved in for the last 15 years. So my topic is going to be mainly to kind of tie everything up that you've been hearing all along. So this is what's going to be happening. So as you know, probably you know the statistics in falls. Falls are the leading cause of injury among older adults, older Canadians. 1 in 3 seniors fall each year. Falls cause 85% of seniors injury-related hospitalization, and also 95% of hip fractures. Over 40% of people admitted to a hospital or long-term care facilities are fallers. As you know, every day 3 adults in BC die from a fall-related injury. So 50% of the falls are from home. So, but the good news is most of the falls are preventable. So if you look at what occurs in the home, and I think majority of you are in homes, so 35% are outside the home. And when you look at it, most of them are in the home, most of them are in the bedroom or the living room. And when you look at the statistics of when it occurs, morning, afternoon, and evening are about the same. The night is only 8%, so most people are sleeping at that time. So what can you do to prevent falls? One is vision, as you heard from Humera, that vision is really important. So if you look at the interventions to make sure you have correct vision, you have clean glasses. It's amazing how many people in long-term care that I work in don't have clean glasses, and they get really foggy. Proper lighting is major. Avoiding multifocal lens like a progressive, in which when you're going downstairs is a major tripping hazard because you can't see the depth perception on it. Using eye drops correctly, which is really important, and modifying your environment. So if you look at the next two slides, what is easy to see? This or this one? So of course you can see there's a contrast. You can see the edge of the bed, which is really important so you don't knock or trip on it. The other slide, what do you see for stairs? And this one. This one's a major issue because people going up and downstairs, if they don't see the edge of the stairs, they trip on the stairs and fall. So the other one that also been alluded to is medication. And if you know medication affects you in different ways, the drowsiness, so when you wake up, you don't know exactly where you're going, your fracture risks, in which it may decrease your bone strength, your bleeding risks on that, decreased blood pressure, in which when you stand up, you may have a decreased blood pressure and then you can faint or get dizzy. Decreased blood sugar, vestibular, visual disturbance, dizziness, and also decreased coordination on that. So if you have decreased blood pressure when you stand up from lying to standing, this is what you should be doing. Pumping your heel before you stand and just getting, moving your calf muscles or using your calf muscles so that you can get some of the circulation going on that. So the other one that is also a major thing and it's been also talked about is home safety, removing risk factors. So you remove things you can trip over, like books, shoes from stairs and places where you walk. And I see the other one is a small throw rack in which people trip over them because they're shoveling and don't pick up the feet when they're walking, or the rug moves and they slip. Keeping the items that you use often in cabinets that's lower and you don't have to use a step stool. Improving lighting in your home, like hanging a lightweight curtain or shade to reduce the glare, and consider using night light so that when you get up, you see where you're going. The other one that is in the bathroom is using non-slip mat, because when you come up, you may be dripping wet and you can slip. Um, Having grab bars next to the shower or toilet so that you can assist you to get up. Having handrails and lights to be on all stairs. Wear shoes both inside and outside. Avoid barefoot, because barefoot you can slip on things, and wearing loose and floppy shoes, slippers. So choosing a proper safe shoe is really important. I've highlighted all the things, but one of the major things is having to prevent from slipping is a non-slip and not sticky sole, because I've seen people with really slippery slippers that they actually wear inside and outside and can slip really easily. The other one that's really important is padding a heel collar to make sure you hold your ankle in place. So really important is no high heels and no slipper without collar, the heel support on that. And as Homera had talked about, making transfer easier, the bathroom is a major issue, in which you can use a bench to transfer. It can be bulky because sometimes with the bathroom in an older building or in an apartment, there's hardly any space on that. The bed rail is really nice and stable and effective. It goes underneath the mattress. It helps you to get up. The handy bar is great for getting in and out of the car on that. It fits in the door latch. So staying organized is also major importance, because if you look at this picture, which hopefully none of you are like that, in which there's clutter all over the place and it's hard to find things. And if you're trying to reach for things on the ground, you may be falling on that, as compared to this, which is really organized and less cluttered, definitely on that. The thing that you can wear around the house or even outside that prevent you from having a hip fracture is hip protectors. How do they work? They absorb the impact and divert forces away from the bone. hip fracture can be prevented or reduced. It can, with hip protectors, it can be reduced by 70% on that part. And there's many types, if you can see. In Fraser Health, we recommend the Blue Tree, Hip Saver, and Safe Hip on that. So you can have different, depending on your lifestyle and what you need to do. So the last thing that is my kind of, what do you call it, my special area is exercise, reducing your risk by exercise. So Canadian Physical Activity Guidelines is 150 minutes per week, and improving balance and strength and have health benefits. And I know for sure that only 11% of Canadians meet this guideline. Now, if you cannot meet this guideline, I think most people can. You can do it within increments rather than a whole half an hour. If you can only do 5 minutes, do 5 minutes every few minutes. So exercise alone is as beneficial as a multifactorial falls prevention program. So in order to prevent falls, the most effective component is balance for one thing. There's a Tai Chi balance classes, strength using resistance. Your body weight is a resistance if you're using it. Balance and strength can reduce falls up to 50%. Walking does not improve balance or strength. That's important for your health and mobility. And a lot of people do the walking because it's easy to do. So that's why. So tips for increasing your activity. Okay. Some of these things I ask people to actually do because they said, well, I cannot do half an hour. I cannot do 15 minutes. I cannot do, but they sit and watch TV the whole day. So I say to them, if you do 5 minutes with every advertisement that comes on, then you can actually do some of these things. Sitting down slowly, no plopping, no dropping down to a lower level in the chair on it, or getting up. Even the whole thing of getting up and standing up for 1 second and coming back down is important. Taking a scenic route, if you can go walk, take a longer way or walk a little further. Exercise while waiting for the kettle or toaster. I usually get people to just within balance or do some knee bends or anything in that way. Aim for 10 minutes of activity at a time, if not at least 5 on that. Balance when you're brushing your teeth on that. Anytime you're at the sink, you got something to hang on to. Go to exercise class if you can. With COVID, it's hard. Challenge a friend, call a friend up and ask for accountability on that. Using activity tracker in which you walk 8,000 steps. Is that your goal? Is your goal like 6,000 instead? Can you make sure you aim for that? Move more, sit less. Whether it's 5 minutes at a time, take a rest for 10 minutes, do another 5 minutes on it. So I know Omara did allude to walking aids. These are some of the walking aids. And one of the things that I usually get people to start with is the walking poles. It does help in walking. If you can't, then the 4-wheel walker would be great on that. So if you look at tips for walking aids, just some of the tips that would be helpful is using a cane on the opposite side of the left of the weak leg. Walking aid should be at the wrist height and not bending down too much. Always lock your brakes and walkers when getting up or down from a chair or when you're having it to the side. Making space in your home for your walking aid, that's really important because some people leave it somewhere and then walk and then come back to it. So that's why. If you're going up and then downstairs, up with a good leg and down with a bad, stay close to your walker, because usually the walker will fly away from you if you don't. Don't pull on the walker to get up. Use your armrest. Walking poles definitely is great for walking, for stability and balance. So the other thing that I always say to people, that they're all things that, but there's a fraction of people that are really like to take risk-taking behavior, whether they decided that they can actually do it and they don't realize. So I usually say to them, make sure you think before you act. It's really important. Thank you very much. I'll give it back to Omera.
No, that's excellent. Thank you so much, Ming. I see some questions coming in. So how about we go ahead and get started with answering those? One individual has said that being a heavyset man with SBMA, I have fallen multiple times and can barely get myself up without using a chair or other piece of furniture to help me get up. Any tips or medical aid to help someone get up? Any tips on mobility aids to help with that?
This is really hard, because usually with a heavier set man, it's the weight of getting someone from a lower ground. You're not sitting or anything, that it's hard to get that person up. So especially when you don't have a chair or someone to pull up on. So I usually suggest the tip is usually getting a medical person to come and help you up, because it's really hard to get that person, especially when you can't use your legs. It's the legs that need to be coming up, pushing you up on that part.
Very good. Probably I should invite Marie-Helene. I know she's on the call. I mentioned she's one of our directors of mission, and she helps to oversee our equipment program. Marie, can you speak to, I believe, is it an app in Quebec that some of our clients are using to being able to alert someone should they be at home alone and if they fall? Can you speak to that?
Oui, en fait, c'est un système d'alerte d'urgence. Alors, les gens portent ça sur eux. Quand ils tombent, ça rejoint automatiquement les services d'urgence qui vont appeler ou envoyer des services d'urgence directement à la maison en cas de chute.
Thank you very much, Marie-Helene. And this is a comment in the chat box that I see, that the best way to exercise for them, and I have seen this in the literature, is around in being in the pool. So I have seen hydrotherapy, aquatic therapy is really helpful. And as Ming talked about, that critical importance of engaging in exercise. Another person mentioned that when I talked about muscle weakness and balance, they have CMT and don't experience as much muscle weakness, but peripheral neuropathy. And I would say that combination of peripheral neuropathy, a foot drop potentially in individuals with CMT, or even the joints giving up, could increase that risk for fall. Another question or comment that is provided is, try using a stepwise way to get up from the floor to a low bench or a pile of books, then to a higher surface, then use that extra height to get up. That seems to be a suggestion that is probably being proposed. Marie-Helene, can you tell us the question in French that we have received?
Oui, alors dans le corps, on n'a pas seulement deux muscles. Qu'est-ce qui est mieux? Faire 25 minutes d'exercice par jour qui sollicite 30 muscles pendant un mois entier, ou plusieurs types de petits exercices qui sollicitent beaucoup de muscles, mais vraiment pas longtemps?
Ming, were you able to hear the interpretation?
Yeah, I am, but I don't understand.
Yeah, I believe it's around frequency of or duration of the exercises, and whether they target certain muscles. So is there a certain prescription that you kind of broadly prescribe when you're thinking about should you spend more time on one muscle group or spend a little bit of time on different muscle groups?
If you can, spend a little bit of time on for muscle groups, because in actual fact, all your muscle needs to go together. like your arms need to push if you need to stand up. Your legs need to be able to walk. That's why when we prescribe exercise, we do the ankle, because you can trip over a foot that has a drop. When your ankle muscles are not as strong, we focus on the legs, the quads, the big muscles, the hips, and the core, trying to get someone to stand up really straight and not move around and not sway when they're doing the exercises. So that's why on that. So if possible, do all muscle groups as much as possible. And the prescription I usually get is do as much as possible, because 150 minutes a week is what you need to target. But some people can't reach that. So if you can do 5 at one time and do 5 later, and then 5 later, you may even attain your 20 times of that muscle in that whole time. So I say to people, if you brush your teeth 3 times a day or 2 times a day and spend 10 minutes each time, you've done 20 minutes. And where have you, whereas you cannot focus on 20 minutes at one time. So that's why it's really important to do as much as you can.
Thanks, Ming. Another question we received is, since I did mention hearing loss, whether there's any literature to support that hearing loss and neuromuscular conditions are related to one another, or whether you are at higher risk for hearing loss. So it is well documented that individuals with different types of muscular dystrophies like FSHD can experience what's called sensory neural hearing loss. That means that it's a permanent hearing loss with damage to that cochlea, the inner ear. Typically, if someone has a sensory neural hearing loss, then a hearing aid, and if it's profound in nature, then a cochlear implant would be an assistive device that they could use. In addition to that, there is literature that for individuals with CMT, Charcot-Marie tooth, that could damage the myelin sheath, it could damage the nerves, and can contribute to also a sensory neural hearing loss. So there is research to support, but it does depend on the specific neuromuscular condition. The next question is from a client of ours who has inclusion body myositis. They're in an electric wheelchair. They attend the gym twice a week and they swim once. They make themselves walk on a high armed walker for about 10 meters a day. Is that not worth it if you suggested walking doesn't do much, or would you say no, continue as is?
I would say continue. The reason why I say walking doesn't do too much is for people that can do more. When you think about it, if you can do more and you think all you do is walking, then it doesn't help that much for your strength and your balance. But if you're in a wheelchair and you're doing your swimming and you're trying to walk, you're actually exercising and getting the muscles working, and also getting your core going, and getting your circulation going. So I would say continue with it. It's really important to do as much as you can.
Very good. Marie-Hélène, I see another question. Can you go ahead and tell us about that question?
Oui, alors pour quelqu'un qui a un problème d'équilibre dû à l'ataxie, qu'est-ce qui est le mieux, un entraînement cardio ou un entraînement musculaire?
Can you translate?
Yes, of course. The question is, if someone has a balance problem, such as they're mentioning here ataxia, would it be better to have cardio training or muscle strength training? Which one would be better if they have an existing balance problem?
I usually go to whatever you can go to, meaning cardio, you're trying to do what you call quick reps quite quickly. With your strength training, you can do not quick ones, because you're not trying to get your heartbeat up. So all depends on your ability, because with ataxia, sometimes the quick movement can actually get you falling. because in order to get your heartbeat going. But a lot of people I find when they are on strength training, if there's enough of it, you actually can get your heart rate up on it because you're actually working quite a lot. Especially with strength training, you are making sure that you engage your core, you're really stable and all things. So, all depends on your ability to access some of those things. And I would lean more towards strength training than cardio on that part.
Very good. Thank you so much, Ming. So I don't see any additional questions, but what I'd like to do is to thank PTC, Roche, and Novartis for supporting education initiatives like this and for their ongoing collaboration with MDC. I wanted to thank all of you for joining our webinar today and for those that have joined our webinars throughout the month as part of our virtual neuromuscular conference. The recordings of the sessions, if you've missed any, are on our MDC YouTube page. I welcome you all to email us at research@muscle.ca. Thank you all for your ongoing support. If there are any additional questions, we'd be happy to also take them and respond to them as part of our research hotline. Thank you so much to Ming for sharing her insights and practical strategies in keeping safe and reducing falls. Thank you all and have a good rest of your day.
Thank you.